going to talk about understanding the significance of coding infections on the MDS. And you've already seen that. So first, a disclaimer here. Everything is current as of today. I check to make sure every morning or every time I give a webinar to make sure that CMS did not make any changes the night before that they pushed out. So you always do want to consult your RII manual and all other CMS memos, guidelines, manuals. I'm going to be talking about some quality measure information and a couple of other things. So always use the most current information. And if you have coded your MDS in the past based on a different coding guideline, you want to save your old manuals to make sure that you have proof that this is how it was supposed to be coded at that time. So again, trying to make sure that everything is current and up to date and use your most current information, including your coding manuals, everything. There are some reference links at the end of the slides. I tried to give you as many references as I could possibly put there for things that I refer to during this presentation so that you can find them just as easily or even more easily than I did. And without further ado, we will get going here. Our objectives today, we're going to review the MDS definition of active diagnoses in the last 7 days, because this is on audits. I'm a consultant. We do lots and lots of audits, and active diagnoses in the last 7 days sometimes gives us trouble because there's different criteria that we have to meet. And then we're going to focus drilling down a little more on the significance of accurate coding of infections. We're going to look at the connection between MDS coding and your facility data profile, which is what you're putting out there into the universe when you fill out your MDS. I'll talk about coding strategies, some documentation and tips for being compliant while coding the MDS, specifically infections, but a lot of this applies to all diagnoses. So that's an added bonus, and some pitfalls of inaccurate MDS coding of infections. The first thing we want to look at here is how is my MDS used? And this picture always kind of reminds me of an octopus with the MDS as the body and everything else as the legs sticking out. Your MDS is related to your quality measures. We have MDS-based quality measures, we have claims-based measures, but most of our measures are based right from how we code the MDS. And some of those measures are used for 5-star, some are not. So we have 2 different places where quality measures come in, and some of them are used in your 5-star calculation to give your overall stars. They're posted, some of them are posted publicly on the Care Compare website for CMS. So anyone who wants to look at your facility, whether it's a consumer or your hospital partners, also look at Care Compare. Your HMOs look at Care Compare. Accountable care organizations, they also look at it. They look at your 5-star rating, they look how you're doing in QMs, they look at your survey measures. Also survey measures. There are quality measures, and then there's additional measures that, although not publicly reported, the surveyors can see those on your CASPR reports. So something to keep in mind, if you can see it on your CASPR reports, your surveyors can also see it on your CASPR reports. Our MDS, we have a quality reporting program for our Medicare Part A residents. There are many MDS measures that come from the MDS. Some are claims-based, but many are MDS measures. Audits goes without saying, lots of audits going on, different MACs, different contractors. The MDS is also used in any complaint investigations in addition to your survey, because one of the first things they ask for when they come in on a complaint is, can I have the BIMs from your MDS, or can I have the entire MDS? It's used for reimbursement, which is a whole day in itself, so we're not going to talk about that. And it's also used in legal cases. The MDS appears, you get questioned. If you've never been in a deposition, good. But in legal cases, how the MDS was coded and the MDS definitions and criteria often comes up in legal cases too. So our MDS, I always like to say, and especially because I am an old MDS coordinator, the MDS is one of the most important documents we have in our facility. So first we'll talk about active diagnoses, and then we'll get to coding infections. For the active diagnoses in section I, the intent is to code diseases and conditions that have a direct relationship to the resident's current functional status, their cognitive status, mood and behavior status, medical treatments, nursing monitoring, or risk of death. So one of the important functions of our MDS is to generate an updated, accurate picture of the resident's current health status with all of our team using the same observation periods. So we're getting a picture of the resident at a snapshot in time generated by the assessment reference date. What this section is looking for, whoops, let me scooch up. Is that better?
Yes, that's better. Thank you, Alicia.
Okay. Yeah, I was sitting back too far. Okay. So one of our important functions, again, an accurate picture of the resident's current health status. And by current, that is as of the assessment reference date. One of the questions it asks us is our primary medical condition, the ICD-10 code in item I0020B. That is mainly asked on our Medicare Part A residents. Some states are requiring it on the OBRA assessments, but their primary medical condition, why is the resident in the facility for their Medicare Part A stay, and then our other active diagnoses in the last 7 days. And this further breaks it down a little bit. Again, I0020B on our Medicare Part A assessments, the diagnosis that best describes the primary reason for the resident's Part A stay, which may or may not be one of the infections we're going to talk about. Then we have our OBRA assessments. Here it would be the diagnosis that describes the primary reason why the resident is in the facility, not necessarily for payment, but why are they here? These are not required by every state, so they may or may not be required by your state. You would need to check with your state RAI coordinator to see if you're supposed to be completing that for your OBRA assessments or not. But our medical record sources for this include history and physicals, transfer documents, hospital discharge summaries, provider progress notes, and other resources in the medical record. But again, a diagnosis can only come from the resident's provider. So the physician, the nurse practitioner, a physician's assistant, clinical nurse specialist, if that's allowed in your state. So if somebody can prescribe, they can diagnose, but no one else can give a diagnosis. So that's important to keep in mind when we're coding from progress notes and other assessments. Then we have our section I-100 through 8,000. These are specifically active diagnoses in the past 7 days. This looks at active diseases and infections that drive the current plan of care. They have, again, a relationship to the resident's current cognitive, functional, mood or behavior status, their medical treatments, nursing monitoring, or risk of death during the 7-day look-back period, except our UTIs, which looks back 30 days. Essentially, our active diagnoses have 2 look-back periods: identification of the diagnosis by the physician in the past 60 days. Again, that could be the physician, the nurse practitioner, other non-physician provider who is allowed to diagnose. So that has to be somewhere in the record identified in the 60-day look-back period from that assessment reference date. Then it also has to be current and support that it's current in the 7-day look-back period, again, except UTIs, which is 30 days. Listing a diagnosis on the resident's medical record problem list is not sufficient for determining active or inactive status. There has to be some sort of support for how it is actively affecting that resident. And to help us out, determining if a diagnosis is active, we need to see specific documentation of the diagnosis by the provider. Again, in the past 60 days and something in the past 7 days that tells us that this resident has this diagnosis and it's currently active. It's not a resolved, it's not a history of, we're currently keeping an eye on the resident for something, we're monitoring them for something. Excuse me. It could also be if we don't have specific diagnosis from the physician in the past 7 days, we might have documentation that there is an exacerbation of it or a recent onset. That could be from a positive lab test or radiology. It could have been a hospitalization for acute symptoms, a recent change in therapy in the past 7 days, but something that tells us they're having a recent onset or exacerbation. It could also be symptoms and abnormal signs indicating something's going on in the last 7 days. It could be a notation in the progress notes. It could also be orders for medications or treatments. So we might have an order for a medication for a diagnosis, an order for a medication to prevent exacerbation of a diagnosis. It could be a long-term medication for a chronic condition that somehow we have to show it's still current. For example, a resident who has a diagnosis of COPD, our current status could be that they have an order for either regular nebulizer treatments or as needed nebulizer treatments, but we're documenting that we either need to use that or we don't if it's a PRN. It could also be therapy orders. So for physical therapy, PT, OT, speech, respiratory therapy, or it could be for nurse monitoring. Now, if we have our care plan that says we're going to monitor for something, we actually have to show that we did monitor for it and what did we see. So not only are we monitoring for it like we said we would in the care plan, but can we prove it? Because we know that's a big piece of being audited and our survey. Did we do it? Can we prove it? So lots of ways to show that a diagnosis is active other than writing a note that says this diagnosis is currently active in the past 7 days. So anywhere in the record that it indicates it's active. And our focus today is some of the infections. This is a picture right from the MDS, from section I with our infections. We have our multi-drug resistant organisms, pneumonias, septicemias, tuberculosis, again, active in the past 7 days. Our UTIs in the past 30 days. They also list viral hepatitis and wound infections other than the feet. They have also foot infections are listed, but these are the top that are check boxes on the MDS. There's also some infections that you might either want to give a more specific diagnosis in section I-8000, or you can just leave it as a checkbox. With our multi-drug resistant organisms, these are predominantly bacteria resistant to one or more classes of antimicrobial agents. I gave you a whole list here. We're not going to get into talking about what is and what isn't a multi-drug resistant organism. We have some popular items on the left side on the column, our MRSAs, our VREs, ESBL. What is very important here when you're coding these is to know what is considered a multi-drug resistant organism. You can use your websites, you can use reputable websites, I should say. I probably wouldn't use Wikipedia, but the CDC keeps a list of multi-drug resistant organisms. The World Health Organization website's a good place to look. Also, the National Institute of Health. If you're coding something as a multi-drug resistant organism, of course, you want to keep your source that you used and the date that you used it, because some things get added. Unfortunately, we rarely have something taken off the list, but things get added, like the Candida infection. That's a newer one, not new, but a newer one that's been added to the multi-drug resistant organism list. So you want to keep up to date on what's considered a multi-drug resistant organism. Our pneumonias could be anything: bacterial, viral, aspiration pneumonia. It's a pretty broad definition. It just says pneumonia on the MDS, but we need to have documentation to support that. So from the physician, we need a physician's diagnosis, and they base that on the symptoms, maybe a chest x-ray, blood tests or blood cultures, pulse oximetry, sputum tests, depending what they're looking for. But again, has to be diagnosed by a physician. We can't just say that they have pneumonia without that physician's diagnosis. Whoops, well, we don't want to go too far. Our septicemia, that's one of our other options on our MDS, defined as the presence of pathogenic organisms in the blood. Some people use the word septicemia and sepsis interchangeably, but technically they're not the same thing. Bacteremia is just the presence of bacteria in the blood. Septicemia happens when the bacteria enter the bloodstream, multiply, and spread, which can trigger sepsis. And then we would see signs of sepsis, the rapid pulse and respirations, elevated white blood cells, possibly the beginning of some organ failure, which can then lead to septic shock, and that's a life-threatening issue. So again, diagnosis before we coded on the MDS, the presence of symptoms, some blood tests, septicemia versus sepsis versus bacteremia. But again, where's the physician's diagnosis and where's our support before we code this on the assessment? And our UTIs, our look back period is 30 days on urinary tract infections. We have 2 criteria to code them and both have to be met. We have to have the evidence-based criteria, whether we use the NHSN, the McGear's, or the Loeb's criteria. And we have to have a physician or a non-physician provider documented UTI diagnosis. With our regulations, in our Code of Federal Regulations at 483.80A, you don't have to memorize that, but I'm sure our infection prevention and control specialists know this. With our infection prevention and control program, we have to establish routine, ongoing, systematic collection, analysis, interpretation, and dissemination of surveillance data to identify infections. So our system has to include a data collection tool and the use of nationally recognized surveillance criteria. Facilities are expected to use that same criteria chosen for their infection prevention and control program to determine the presence in a UTI. So your facility has or should have an infection control policy that tells you which criteria you're going to use to determine if the resident has a UTI that should be coded on the MDS or not. Because I'm going to talk about quality measures. We want to code things accurately. We want to make sure we do code any diagnoses that the resident has, but we also don't want to code something that we don't need to code. So using that infection control, for example, we have the NHSN criteria. Those definitions have specific criteria for symptomatic UTIs without an indwelling catheter that has that algorithm with the fever, symptoms, urine culture results, for example. They have another criteria for catheter-associated UTI and one for asymptomatic bacteremic UTI with or without an indwelling catheter. And I'm not going to do a infection prevention webinar here today, but keeping in mind, whatever your facility's policy, whatever evidence-based criteria you're using in your infection control program, that's the same one that you should use when you're deciding if something is in fact a UTI or not. With our UTIs, because this is a big one that we deal with in facilities a lot, it's also one of our quality measures again. So continuing on that, for our residents on admission, entry, or re-entry, we don't have to use the evidence-based criteria as long as we have that physician diagnosis and it's documented prior to admission, it would be sufficient. So we would still need to maintain that in our medical record. If the resident is transferred out to the hospital from the facility, but they're not admitted and they come back, we do have to use the evidence-based criteria to evaluate and determine if the criteria are met and verify their supporting documentation of that diagnosis from the physician. So we do want to keep an eye on that based on whether or not the resident is a new admission or a readmission from a hospitalization, or if they went out to the emergency room, so it makes a difference. And that's something that under infection prevention, your surveyors might be looking at to determine if you coded it correctly based on whether or not they were a readmission and came from the hospital, or they were in your facility, or they went to the emergency room. All right. So one of the things that we look at, and that one of the things that is associated with coding infections on our MDS, because it's not just coding it on the MDS, it affects our quality measures, our percent of residents with a urinary tract infection. We have several measures being reclassified. This is not one of them. So these are publicly reported on CMS Care Compare. So consumers can go onto the website and they can look at what percent of our residents have urinary tract infections. It's also used in as one of the measures in your 5-star calculation. If you have an issue on your survey with infections, that also can affect your 5-star because our health inspections are part of the 5-star calculation. It's reported in the I-keys on Casper. And like I said, if you can see it in your I-keys on Casper, your surveyors can see it in the I-keys on Casper, so they can see what percentage of your residents have an issue with urinary tract infections. And that may be something that if you flag high for it, they decide that's going to be one of their focuses when they come in to do their annual survey. There are some exclusions on this measure, but they're very few. So one is that the target assessment is admission or a 5-day PPS, which would exclude you from triggering this measure. Again, also with the evidence-based criteria, so they're giving you a break a little bit if your resident is coming as a new admission or if it's a 5-day PPS assessment because they've been in the hospital. The only other exclusion is if in I-2300 UTI that information is missing, if it's dashed out. That's really not an item that you would dash out because if they don't have a UTI, you would leave it blank. So putting a dash in that space would not really be appropriate. If you have a lot of dashes in that space, you want to take a look at that. Your quality reporting measures can affect that. So everything is connected to each other here. If we have a lot of UTIs, we're going to trigger high, and that should lead us to check our systems, maybe look at our MDS coding, look at our infection control program. When something triggers high in our quality measures, we don't want to jump right in and say, oh, it's the MDS coordinator, it's all their fault. We have to check everything because our quality measures really were for us to look at any issues that we had in our facility and to look at our systems and hopefully correct that issue. They're now publicly reported, but initially it's supposed to lead us to look at our systems. So that's one of the first places that coding a urinary tract infection will affect once it's on the MDS, also in your quality measures for all the public to look at, and they can make a determination of how they feel about that particular issue. We also have our SNF, healthcare associated infections requiring hospitalization, our quality reporting measure. This one doesn't come from your MDS, it's claims-based. But again, having infections, having a high rate of infections is going to affect this. We're also possibly giving our information to the hospital stay. If the resident has to go to the hospital, that diagnosis shows up on the claim. It's identified using the Medicare inpatient claims on facility residents, some things that are included, and there is a big list. If you go to the manual, there's a whole manual that talks about this quality reporting measure. Just broadly, UTIs, pneumonias, sepsis, and cellulitis. So UTI is a quality measure. It's associated with healthcare associated infections requiring hospitalization on the quality reporting side. So again, all connected. We also, and hopefully this is not upsetting to too many people, we have also our MDS on our CMS 802 has all of our infections listed. It pulls from the MDS if you use an EMR to do this. Back in the day, we used a pencil, or at least I did, a pencil and the instructions and going through all the residents' charts to fill this out correctly. But using the EMR, it pulls from the MDS. It's to be reflective of all the residents as of the day of the survey. So here's a place that it's going to pull from your MDS and show they have an infection. You want to check that and make sure it's correct as of the day of the survey. Your MDS could be almost a quarter old before the next one is in there. So you don't want to report on your 802 that someone has an infection that was resolved 2 weeks ago or 3 weeks ago or a month and a half ago. This one also pulls from the multi-drug resistant organisms. It pulls pneumonia, tuberculosis, viral hepatitis. So those are familiar. Those are directly from the MDS. Pulls UTI and wound infections right from the MDS. Some other ones that it pulled that you have to code are C. diff. If they have scabies, a GI virus, COVID, or other, and then you would probably be asked, what is the other? So they're looking at residents who have a communicable disease, not all inclusive. I kind of read what they all were from the 802, but pulling right from the MDS, again, another place that it touches. So we can talk about F tags here. One of the things on your MDS with coding infections, F641, accuracy of assessment. Is it an active infection in the past 7 days and for UTIs in the past 30 days? So first of all, an infection that's resolved. You don't want to code that on your MDS unless it has been active in the past 7 days, meaning it has a current relationship to the resident's status. So are they on a medication for it? May or may not be considered active. They're on a prophylactic medication for UTI. Some people are on it ongoing. That doesn't mean they have an infection. For your multi-drug resistant organisms, is it colonized and it's not an active infection? That would make a difference on how you're going to code that on your assessment. For your UTIs, they may have had a UTI in the past 30 days, but we may be beyond now the 30 days and they're still on an antibiotic for whatever reason. So looking at what is the definition of the past 7 days, and is there physician documentation, and for UTIs, do they meet the criteria? For other diagnoses, do we have that physician support? Do we have the lab reports, the x-ray results? If your MDS, if you code an infection that's not active, first of all, you could be, you're reporting data. So let's face it, CMS gathers data. That's what they do. They're gathering, although it's not publicly reported, they are gathering data on how many residents have a diagnosis checked off of septicemia, how many residents have a diagnosis of pneumonia, how many residents have multi-drug resistant organisms. So even if they're not specifically reported, CMS is gathering that data. And we already have an audit for MDS schizophrenia based on data. So there's other things that CMS could look at based on our data. We want to be accurate, but we don't want to not code something if it is active, because that would also be an accurate assessment. So we need to follow the rules of the RII manual, follow the rules of the documentation. The other thing that F tags, it falls under F880, infection prevention and control. This is probably not the first time that you've heard about F880. I'm not going to belabor that one because we're not talking about infection prevention and control, but one F tag usually leads to another. So if there's an issue with coding the infection on the MDS, that may lead your surveyor to go looking at the infection and did we document it? Do we have our tracking lists? Do we have everything that we need to have? But again, it's our data profile. So if we're coding every single UTI, for example, saying it's urosepsis and coding septicemia, the data that we're putting out is that we have a lot of sepsis in our facility. Is that something that we want to be reporting, that we have a lot of residents with septicemia, especially if they were not just coming back from the hospital? That's other data that CMS can see. They can see what type of assessment it was the resident in the hospital, what diagnoses do they have? Part of your data that you're putting out into the universe. Putting out into the universe that we have a lot of multi-drug resistant organisms and that we don't have a lot of residents who came back from the hospital with them that didn't have it before. So a lot of things that our data could be telling someone that it's not necessarily publicly reported, but it forms a picture on the other end when our data is received. The other thing that CMS looks at is our influenza and pneumovac rates and how many residents have pneumonia, how many residents get influenza. If we code that on the MDS, that's something they also follow. They also follow our reporting. So it's all connected to each other. Again, what is our data picture that we're putting out there? Right. So what does my infection data say about my facility? I was just talking about infection diagnoses on the MDS are submitted to CMS via the I-keys. That's where CMS gathers all of the data about our facility, and they can make connections. They can run, like I said, a diagnosis list of who was a new admission, who isn't, multi-drug resistant organisms coded, wound infections coded, high rates of infection for anything is something that CMS can keep an eye on to form our data profile. But our UTIs are reported directly on Care Compare. So someone looking at that may say, you know what, I don't want to send my family member, they have a problem with UTIs. They also look at from the MDS, they look at our infection, or not infection, our immunizations. So that's all publicly reported too. What percentage of residents have influenza vaccines and pneumococcal vaccines? That's something that consumers look at to decide if they want to have somebody come to your facility. So one of the things that we want to do, if we think we have a problem with infections in our facility, your infection preventionist is probably tracking all of these and on top of it. But the ones that are coded on the MDS, we want to check and make sure, is our MDS coding correct? Did we code something that even came from the hospital that's now resolved? If we're coding it on the MDS and it's resolved, we'd have to be monitoring it to make it an active diagnosis. So if we're not monitoring it because it resolved a week ago and we don't have active monitoring, active diagnosis, active documentation that we're monitoring it, should it even be on the MDS if it's resolved? Did it meet the criteria, especially for UTIs? Because when we see facilities flag high in that, sometimes the issue when we go back and check it is we see that they didn't use the criteria for their infection prevention program states they will, and things were coded incorrectly, UTIs coded that didn't necessarily need to be. Or are we missing, we know we have infections and UTIs, but it's not showing in our data. Do we need to check and make sure that everyone understands what the criteria are and how we're supposed to code those on our assessment? One of the things that having infections flagging high is, do we have an issue with infection control? We might have an issue just on one unit where we have more UTIs than another. Do we need to do a QAPI on this and do a root cause analysis? That's usually the result when we see something triggered high. We're going to do a QAPI for it. Figure out the root cause analysis. Is it a problem with hand washing? Is it a problem with excuse me, with any PPE? Is there something in the system that's breaking down that now we have an issue with infections? Something to get on top of before you end up with an infection control survey. Are we using the same evidence-based criteria in our infection prevention program for our MDS coding of UTI? So make sure that you are. You don't want to say in one hand that you're using the Loeb's criteria and then whoever's doing the MDS and looking to see if it meets the requirements is using the NHSN. So whatever you say you're going to use, that's what you need to use. Keeping in mind, all of our data, again, forms a picture of your facility. I can look at an MDS and see if they have multiple infections coded, like septicemia, MDRO, pneumonia, if all of those were coded, I would start looking into the chart, making sure that that was correct. We have a lot of diagnoses in some of our systems. Pull the diagnosis from the diagnosis list right onto the MDS. That's something that you either don't want to allow it to do optimally, or you want to check and make sure whoever's signing the MDS checks all of those to make sure they're accurate. Some of those diagnoses stay on our diagnosis list forever. You might have one of pneumonia from 2 years ago. So you don't want to have those pulling onto your MDS if they're not correct, especially if we're not checking them and not able to edit that and take them off if they're no longer current. I did leave plenty of time for questions, but again, your data profile, we can't stress that enough. It's all connected. Your surveyors will definitely be looking, especially with all that information on your 802. Your quality measures. Some of your diagnoses are risk adjusters on your quality measures. So again, you want to make sure your MDS is accurate, because you could be not triggering one thing by leaving it off, but not allowing a risk adjustment on another measure. So the main point is accuracy with your assessment, and then making sure that it's addressed on the plan of care, and looking and making sure that we have that infection control program to prevent infections as much as possible. And check those CASPR reports to see what you're reporting. I did give you some references here. I gave you the RAI user's manual and all the errata. We've had several. I gave you a link to the Loeb's criteria, the McGear's criteria, and the NHSN protocols, because again, you have to decide which one you're going to be using with your infection control program. Some other resources here: management of multi-drug resistant organisms in your healthcare setting, the C. diff infection, that's a big one. Coding that one, isolation. I can talk about isolation for a second too. Keeping in mind, isolation for infections, what you can't code isolation for is your UTI, and for wound infections, isolation is for infections spread by droplet, contagious from other people. So C. diff, when you think about that, when you're coding isolation, this is just a helpful hint. Coding isolation for C. diff, did the resident get C. diff from another person, or did they get it because of antibiotics? So that's a hint there too. Management of multi-drug resistant organisms in healthcare settings. Gave you some other stuff about multi-drug resistant organisms, so you have places to look to find out what is considered that MDRO, because again, things change from year to year. And your quality reporting, if you love to read quality reporting manuals. Your skilled nursing facility, healthcare associated infections requiring hospitalizations, the technical report, several pages long. It lists every single ICD-10 infection code that affects this measure. And because this is one of the quality reporting measures that's also reported out in the public, even though it's not driven by the MDS, this one is a good one to look at so that you know which infections affect this. It was, when I read the technical manual, it was many more than I thought it was going to be. Lots and lots of ICD-10 codes for all the infections that may affect this measure for your facility. And like I said, I left plenty of time for questions. Were there some questions for me to answer?
Yes, good afternoon again. So Alicia, we have a couple questions in the chat,
Okay.
and if anybody else wants to add a question, either drop it in the Q&A or drop it in the chat. The first question is, when is it appropriate to use an infection as a primary diagnosis? And if the resident continues treatment such as nebs or oxygen after pneumonia, for example, is cleared, when is it appropriate to remove that diagnosis? To remove the infection is active, and how do you justify continuing the treatment if the infection is diagnosis is removed? Lots in that question.
Let's see, the first part, that one's in the chat box. I'm more of a visual person. I'm terrible like that. An infection could be the primary diagnosis. And again, this is mainly used for your Medicare Part A assessments. Most states that went to PDPM, or states that are using a case mix, or for any of the OBRAs, most states did not request to enable that question, at least yet. But for your Medicare Part A residents, it would be appropriate if that is the primary reason why the resident needs Part A covered skilled care in your facility. So that could be why they need monitoring. It could be why they need an antibiotic or an IV medication. It could also be why they need some therapy. You do want to keep in mind when you're looking up those diagnosis codes, ICD-10 coding is a whole other webinar, but using your ICD-10 coding manual to check and make sure that the code that you're using can be a primary diagnosis. Some of those have to be coded second. So you want to look at that. There were a couple diagnoses that they made in the ICD-10 mapping tool for fiscal year 2024. Some of those infection diagnosis codes are now considered return to provider codes. So looking up the coding guidelines, making sure you're following the coding conventions for things that are excluded. Your software is not going to let you put in a return to provider code. So if that happens, you'll know it should reject it before you get to the whole process of submitting your MDS through the IKeys and having them reject it. But there are several cases where the infection may be the primary reason for skilled care, especially if they're on IV medications when they get to the facility. If they continue the treatments after pneumonia has cleared, when is it appropriate to remove the infection as active? The pneumonia may have cleared on the x-ray, but they still may have the nebulizer treatment just to make sure that they're still have good airway movement. Once that treatment is finished, that's probably when you would take that off of the list of active infections, unless you're going to be monitoring them specifically every single day as part of their plan of care, listening to their lung sounds, all of that. You would probably remove it probably after a couple of weeks. And what to justify continued treatment if the infection is removed? If they're going to continue on nebulizer treatments or oxygen, that would be something to speak to the physician and the provider. They may have another comorbidity. Most of our residents do. Very few people come into the facility with just one diagnosis. Some of even our quality measures, the residents excluded if they don't take any medications, which very rarely happens. So I would speak to the provider, because we also have to have an indication for all of our medications. So I would speak to the provider and see if there's another appropriate diagnosis that goes with it.
Okay, and the next question, is it a good idea to do a SIG change when we are no longer treating the infection coded on the previous MDS?
You don't have to do a significant change unless it actually meets the criteria that's in the RAI manual for a significant change. Just having an infection resolve, I probably would not, unless the resident was so compromised at that time that now that it's resolved, their ADLs have changed, other things have changed that do meet the criteria. Even if you do a significant change 2 weeks later, it's not going for the one that affects your quality measures, your UTI, that's going to stay on there anyway. So doing another assessment isn't going to remove it. But you don't want to miss a criteria for significant change. That is one thing you do not want to do. You can get cited on survey for that. You don't want to miss that, especially with all of our GG items now. Changes in 2 by 1 degree could make a significant change. My best advice is to review what the criteria are. As a side note, we're probably not doing them as much as we should be. There are a lot of different criteria in there about it, but this is not one of them. So you don't have to unless it meets the criteria, regardless of whether they had an infection or not.
Any tips or guidance for the MDS coordinator to track these infections that are showing up on the MDS? Should he or she work with the infection preventionist, the MDS coordinator?
Absolutely. The MDS is a team sport, just like most of what we do in our facilities. Good communication between MDS and infection control, keeping track of these, because we don't want to miss coding one, and we don't want to code something that's resolved that we don't have to code. So always good communication. A good place to be listening for these is also in your morning meeting. If you have a stand-up meeting, whatever type of meetings you have, some facilities have messages in their EMR. But yes, good communication between infection prevention and MDS. MDS needs to communicate with everyone really to make sure everything is accurate. It's a big job. I was an MDS coordinator, so I know. And that was a long time ago. It's much more complicated now.
Another question, can you comment on suppressive therapy with an antibiotic?
As far as Should we code it
Just
as,
a question that came in. Maybe they could
okay,
clarify.
yeah. I mean, suppressive therapy, I wouldn't code it as an infection if it's for someone who has frequent UTIs and the physician orders that prophylactic antibiotic. That doesn't mean they have an infection, so you wouldn't code it there.
Okay,
But
so it
that's
does not get coded as an infection unless there's an active infection, correct?
right. And some people are colonized with MRSA, and unless they are actively have an infection at the time, you wouldn't code that there either.
Okay. You commented briefly on it, and it's something that we're seeing when we talk to facilities with new MDS coordinators and the usage of the EMR, pulling data to the MDS and forgetting to look at what's been pulled. Is that something that you're seeing out in the field, or do you get comments from folks on that?
We have had comments and we have seen it out in the field, and it has resulted in diagnoses being coded that shouldn't necessarily be coded anymore. So those diagnoses, once they go into the EMR list, they don't come out unless someone physically resolves them or whatever you have to do in your specific system to do that. When it pulls right to the MDS, we're signing when we complete that section an attestation that it was correct as to the best of our knowledge. But anything that's pulling directly in, whoever signs that section is still responsible for everything that's coded there. So my best advice is not to pull it and have it pull in the first place. That way, what's coded there was purposely put there unless someone makes a little mistake clicking in the box, which we've all done. You know that if you try to enter your PIN number multiple times. But that way, you know that you put those there. It didn't just pull. It wasn't a software glitch. We've also seen where they end up back in there because of a software glitch. So you want to check those. You can't say enough about periodically doing a self audit. You can have third-party auditors, but self audits, including in your triple check meeting, just kind of giving those diagnoses, all of them, a look at, but especially those, like infections. Is it still active and is it where I want it to be? Because again, we see claims going to Medicare with pneumonia on them, and the person hasn't had pneumonia in 3 years. It got on the diagnosis list, never came off.
Yeah, thank you for that, because that's something that we're finding also, and working with facilities on their infection rates and data. I don't think people realize that sometimes if you use that automatic pull from your EMR, it may get transmitted into your claims and MDS data erroneously, and it's not accurate. And then those of us working in the quality world and on the state surveyor side can see it. So
yes, anything that's in those CASPR reports that you can see, your surveyors can also see. And when they can't cite you from your CASPR report, but that gives them an idea of what to check on when they come into the facility. And if it's infections, then that's going to lead to and to and to. If you look at your guidance to surveyors, which is public information, it tells them exactly where to look next, to tell you exactly where to look next to, so that you can be on top of it. We have to code what's real, but we need to also pay attention to not coding things that we don't have to, or again, on that 802, that's supposed to be current. So if you have MDS data pulling on that, you want to check that before it gets handed to anyone on the survey team to make sure that anything that's not current gets taken off.
excellent. Just for our attendees today, just for your knowledge, Superior Health is going to be working with facilities. This is something that we can assist you with on the auditing of your MDS data and working with you lifetime using a PCC test environment. We will have this set up for PCC starting in February. So if you are a new MDS coordinator, or you're an infection preventionist, administrator, DON, and you're like, hey, I would like you to teach me how to do that audit, please reach out to myself or anybody at Superior Health that you are working with, and we can get you hooked up with some one-on-one training and support in that area. Are there any other questions that we have for Alicia this afternoon?
I was going to say that's awesome. Your quality improvement organizations have a lot of information to help facilities with all of these things, whether you're new or experienced. A lot of good information to help you.
And we are getting quickly up to speed on some MDS training ourselves so that we can help and assist facilities. Is it just PCC? Right now, it's just PCC. However, several of us do have a matrix experience and have worked extensively in matrix. So if you need help with that also, we have worked in, because many of us come from the nursing home world, we all have, and a few of us have had multiple experiences with different EMRs, we can assist. So please feel free to reach out to us. Right now, we only are setting up a PCC test environment, but if you need matrix help or any other EMR support, we can help with that live. We can use either a Teams or Zoom environment to support, which I'm grateful. I think that's a real helpful thing for facilities, especially for new infection preventionists and MDS coordinators.
Absolutely. Being the infection preventionist is, that is not for the weak-hearted.
No, it is not. These are two very, very important roles in the nursing facilities. And really, in the last 4 years, they have really come to highlight the importance of that communication and accuracy in the two areas. So if we don't have any other questions, I'm going to drop in the chat a link to our webinar survey. So thank you, Alicia. Is there any parting thoughts while I do that for us?
Yes, self-auditing your assessments to make sure they're accurate. Using your infection preventionist, reaching out to your QIO for help, because, you know, we just came through a pandemic. Although the emergency is lifted, we still have a lot of COVID, influenza, all kinds of other infections going on out there. Your QIO can help with that. And use your RAI manual and your evidence base to code your MDS to make sure that you're coding what you should and not coding anything that you don't necessarily have to.
Well, thank you very, very much. I put into the chat the link to our survey, and just if you could support us by providing some feedback, we hope to provide additional training and education in 2024 around MDS coding of infections, MDS in general, and then as always, continued work around infection control and healthcare acquired infections, among many other topics around skilled nursing facility and long-term care. So if you have a need or any other additional education requests, please send us a shout and we will work on getting them. Thank you, Alicia, so much for today. Really, really appreciate you doing this.
Thank you for having me. My pleasure.
Yeah. Take care, everyone. Have a great afternoon.